Welcome everyone to October's PrEP webinar. I'm Jen Sperduto, and I'm joined by my colleague Dawn Reinhardt Wood, and we're from the Department of Psychiatric Rehabilitation and Counseling Professions at Rutgers University and part of the Institute for Inpatient Psychiatric Rehabilitation. And today's webinar is on trauma-informed therapeutic milieu. And our presenter today is Debbie Mizell from the Department of State Hospitals in California at Napa. And we're going to tell you a little bit more about Debbie when we get to her intro page. But just so you know, this presentation is sponsored by the New Jersey Departments of Health and Human Services and the Rutgers Institute for Inpatient Psychiatric Rehabilitation. Next slide, please. So this is an interactive training. If you've been here before, you know we encourage you to ask questions and participate throughout the session. We do that via the chat box. And if you can see the chat box, you might have a box that says everyone or just host and panelists. You might want to change it to everyone just to make sure that everyone gets to see your responses, or if you have a question. If you just wanted to go to Dawn or me or Debbie, then you can leave it at host and panelists. A recording of this webinar will be available tomorrow on our Rutgers IPR website. Dawn's going to drop a link to that. And at the end of today's presentation, you'll receive a link to a training evaluation in which you can give us some feedback about the presentation. You can access the slides and handouts for today's presentation, and also get a certificate of attendance to say that you were here today. Next slide. Just a quick disclaimer, the Psych Rehab Educational Program, or PrEP, is an online forum for a variety of topics that are relevant to state psychiatric hospital staff or anyone who works in an inpatient setting. And while Rutgers and DBHS, DMHAS are co-sponsors of the program, the PrEP webinars are peer presented, and as such, the content is independently developed by the presenter each month. So the views and opinions expressed in the program are those of the speakers and do not necessarily reflect the positions or views of any entities that they represent. Next slide, please. Just so you know, we're being recorded so that there's a recording available tomorrow, but just be mindful that anything you say will be recorded. Thank you. Next slide. And it is my pleasure to introduce Debbie Mizell. She's the trauma-informed program assistant at the Department of State Hospitals in California at Napa. She's a level 2 certified clinical trauma professional. Debbie works as a mental health professional and clinical supervisor for the Sonoma County main adult detention facility, providing screening, diagnostic evaluations, and therapeutic interventions to inmates with mental illness, and providing recommendations for special housing and observation to custody staff. Additionally, Debbie maintains a small psychotherapy private practice specializing in trauma treatment. So with that, I'd like to turn it over to Debbie and say welcome, and you can take it from here. Thank you.
Thank you. I'm going to apologize because I have two screens here, so you might be looking at the side of my face for most of this. And okay, let's see. So I always start with this slide, that this term "name it to tame it," that Dr. Dan Siegel uses this phrase, and specifically when you're facing an upset child. But I think it's relevant to people of all ages. And it's based on research that shows that when the emotion center of the brain takes over, that the thinking part of the brain is not accessible anymore. And so for me, this slide has two purposes. So it's going to somewhat lay a foundation of talking about the therapeutic milieu, but more importantly, it's going to directly address my own anxious inner critic, because no matter how many times I present this information, the picture on the left pretty accurately represents how I feel about presenting. So I'm naming it to hopefully tame it, and so that I can get through this information and as effectively as possible. And if I am effective, then hopefully you'll be able to identify 3 common responses to trauma. You'll be able to name, and hopefully you'll be able to do 2 co-regulation techniques. And you should be able to identify at least 2 of the trauma-informed care principles. So we'll start by answering this question, and I'm going to give you guys a minute or so to put some answers in the chat of what would you all consider to be a therapeutic milieu.
Okay, so we have one response so far from Renee, and that is safe place. Tom says the environment supports recovery. Amber says a safe environment. Erica says a place that is safe, and that's from Alaska. We've got safe and structured setting, and one that is physically and psychologically safe and supports recovery and healing.
Great. So that pretty much answered my questions. So very, very simply put, a therapeutic milieu is going to be a healing environment where everyone is as regulated as they can possibly be, meaning patients and staff, and that everybody is going to have at least some sense of safety. And so we can help to make it a healing environment by implementing the 6 trauma-informed care principles. And so I'm just going to go over them very briefly. The first one is safety, and we always start with this one because, for obvious reasons, safety is our number one priority. Um, but all of the other principles really build up to create a sense of safety. And this does include both physical and psychological safety for everybody that's involved in the organization. So in our inpatient settings, safety is generally going to be defined by the staff as maximizing control over the environment, and it's usually defined by the patients as maximizing control over their own lives. Next, we have trustworthiness and transparency. And trust is really built and maintained through transparency by things like authenticity and making sure that people are able to understand their choices. And then we've got peer support, which helps to establish safety. It helps with building trust and enhancing collaboration, and it models recovery and healing, and maximizes empowerment. And the peer support person would be someone who has a shared experience or understanding. So it would be maybe a patient that has been in the system, being a support to a newer admitted patient, or a level of care staff being a support to another level of care staff. And then we have collaboration and mutuality, and this one is really key to leveling out the power differentials between staff and patients, or between level of care staff and administrators. It also demonstrates that healing happens in relationships, and that you don't have to be a therapist to be therapeutic. And then empowerment, voice, and choice is recognizing individual strengths and experiences, and it's going to build on them as well. And it validates the person's experience and puts them in a place of being able to develop new skills. And it's also going to be like the organization as a whole should be fostering a belief in resilience and supporting the development of self-advocacy. And then we've got cultural humility and responsiveness, and this is where the organization as a whole is going to move past any cultural stereotypes and biases. It'll offer gender responsive services, and it recognizes the healing value of cultural connections, and it addresses historical trauma. So hopefully you can see kind of how each one of these principles kind of builds on each other, how they work together to really provide a sense of safety, which ultimately is going to help with implementing a therapeutic milieu. And the reason that these principles are so important is because there's a very high percentage of people in the mental health settings that have been exposed to potentially traumatizing events as children, as adults, or both. There's there's strong evidence that shows that trauma plays a causal role in almost every mental health condition. Exposure to traumatic events is going to increase the likelihood that people are going to use more mental health services and that they're going to need more intensive interventions. So, because these statistics are so high in many mental health settings like ours, we assume that every person that we see that may have had some form of trauma in their background, whether or not anybody knows about it or not. So in our inpatient settings, we're very likely to see cognitive, emotional, and physical responses to trauma. And when we're able to recognize them as being a trauma response, we're going to be better able to respond in a way that promotes a therapeutic milieu. So now I'm going to just see if people can give me some responses about what in the chat, if you can just put in some responses that what kind of trauma responses or chronic stress, what kind of responses do you guys regularly see in your work? And they can be from this list or um, in addition to this list too.
So we're seeing a lot coming in, hypervigilance, hitting, physical agitation, irritability, substance use and homelessness as people enter the system, aggressive behaviors, aggression, a lot of aggression, guilt, blunted affect, the numbness and detachment, headaches, body aches, tiredness, so the somatic complaints, being guarded, sleeping difficulties, anxiety in general.
I can relate.
Violence.
Yeah, obviously that goes back to safety being our main priority, right? That we do definitely see a lot of aggression and violence, and a lot of that comes out of past experiences and having to find some way to feel safe.
We have a couple well, we have the sleep dysregulation again, but another one that I really wanted to mention that somebody said that Christine sent in was gender preference for care, which, may relate to physical or sexual violence in the past.
Right. Yeah. Great. Those are some great responses. And recognizing that stuff is really kind of the first step, right? And then polyvagal theory can help us to gain a better understanding of these responses and how to treat them. So polyvagal theory was developed by Dr. Stephen Porges, and it helps us to understand how the brain and the body work together. The vagus nerve is the largest nerve in the body, and it connects the brain to the heart and to the belly, and it's where we physically feel all of our emotions. Polyvagal theory also teaches us that our autonomic nervous system can trigger another person's autonomic nervous system, and then we can unintentionally trigger a trauma response in someone, which is why it's so important for us to be able to be regulated in order for us to provide good care to other people. So I'm not going to go into a lot of detail with this chart, but I just wanted to point out that for us to have a therapeutic milieu, that we need both staff and patients to be in this green social engagement center as much as possible. So when we, as the staff, are going to be socially engaged, that's when we're going to be the most effective at helping there to be a therapeutic milieu. I wanted to point out too that Stephen Porges uses this term neuroception it's this subconscious process where the nervous system detects and evaluates cues for safety or danger in the environment, and it helps us to distinguish whether a situation or a person is going to be safe or dangerous or even life-threatening. So it's not something that we are consciously thinking about, but something that is just kind of in the background happening. I think that I have time to add in here the hand-brain model, which so okay, if you can see my fist here, Dan Siegel does the hand-brain model where this part of your fingers is going to be the cortex, and it's the last part of your brain to develop with all of the thinking and reasoning, the abstract thinking, pros and cons, all of that, and then in the middle here is going to be the limbic system, where kind of the emotion control center, and then we've got the brain stem with all of the automatic processing and breathing and heart rate, that kind of thing. And so when somebody's in the social engagement center, their cortex, the thinking part of their brain, is going to be online. But if they perceive a threat, then we flip our lid, and this part of your brain is no longer accessible. And so we're not able to think clearly and rationalize a situation, and whether it's an actual dangerous situation or if it's just a perceived danger based off of some past experience, if we've triggered some kind of trauma response. So people flip their lids and then go into this fight, flight, or freeze area where we're not able to have that that interaction with them. And so this is where our milieus can become not therapeutic. Do we have anything in the chat about any of this, or any questions or comments?
No, not at this point.
Okay. So some milieu interventions. So obviously there are a lot of different interventions that to use in the milieu, but we're going to focus kind of on grounding and co-regulation, which at times need to be used together too. So this slide comes from Winona State University, and it's just talks a little bit about grounding, but probably the most common way to think about grounding is literally grounding yourself or anchoring yourself into the physical environment, like feeling the pressure of your feet on the floor. And grounding is especially helpful because you can always revert back to your 5 senses to ground yourself in the present moment. They have these 3 different types of grounding: the mental, physical, and then the soothing. The one that I find to be especially useful in a more acute setting is going to be the physical grounding and being able to focus on those senses. And you can do it anywhere, and nobody even has to know that you are doing it. So the important thing too is that we are able to be grounded. So we need to use these a lot of times for ourselves in order for us to regulate with other people and to be able to help to be therapeutic. So these are just a couple of examples of ways to ground yourself or to reset your nervous system. I like this 5, 4, 3, 2, 1, which is just going to be noticing all of your senses. So you would go looking at you could find 5 ways, identify 5 ways, 5 things that you can see, and then 4 things that you can touch, like 4 different textures that you can feel, 3 different things that you can hear, and then 2 different things that you can smell, and 1 thing that you can taste if you're able to do that. Now, whenever I do this, I always tend to forget at least one of the senses, but you can use kind of any variation of these things to be able to ground yourself and to be able to reset that nervous system. There's also the square breathing or the box breathing, which is just breathing in for 4 seconds, holding your breath for 4 seconds, breathing out for 4 seconds, and then holding your breath for 4 seconds, and then you can repeat it as many times as you need to. So the point of this too is that we have to learn how to do it ourselves so that we can help other people do it. And if we are grounded, then we'll be able to co-regulate with other people. We can help them to do it. Once we're grounded and we're in that social engagement system, then we can model regulation through facial expressions and body language, by maintaining the volume and the tone of your voice, but also by limiting how much you're saying and simplifying your language, because referring back to both to the name it to tame it, but also to like the flipping your lid. If a person is in that fight, flight, or freeze response, then they're not going to be able to be having a rational conversation. You're not going to be able to talk them through regulation in that moment. And um, so we've got to kind of simplify the things that we're saying. And you might have to adjust the environment, maybe even going to a different location. And you can always invite the person to join you in regulating if they're able to, but very often co-regulation is done without the other person actively engaging in it with you. Okay, well, I talked especially fast today, apparently. I do have some questions for people to, but if anybody has anything that they wanted to talk about, if there's any more questions or comments in the chat.
So we have one question from Tom, and that is, what is the role of procedural justice? Or what about the role of procedural justice? And Tom, if you would like, I could give you microphone, I think. Let me see here. If you would like to speak more to that, one moment. You should be able to talk, Tom.
I'm alive. Yeah, so I study inpatient violence, and one of the things in the literature is reactive violence is that people, they may be predisposed because of their trauma history or their biology or any number of things. And so that in the area of reactive violence, oftentimes people react to procedural justice, meaning I'm not being treated the way other people are treated, or you're singling me out. Just curious of your thoughts.
On how to engage that?
Well, the role of milieu management, and it strikes me that the milieu or the unit is often the source of a lot of iatrogenic things, meaning patients feel provoked or they feel mistreated, and they may also they're just kind of like, to your point, like running a fever. In other words, they're already stressed out just being in the hospital. And so I'm curious about your thoughts about managing the milieu from the perspective of not provoking, thoughts on not provoking these responses.
Well, I think that we can always kind of go back to validation in validating somebody's feelings, whether or not their perception or their experience of it is always going to be valid, right? That we may not agree. I think that in our setting, we have patients that come to us that are not here voluntarily, or in the legal system, they don't choose to come most often, and that but we can still validate that experience of them ending up in that situation, right?
Absolutely. Yeah, we have a technique here in New Jersey we call 3 steps to safety, and the first step is to validate for that exact reason.
Yeah. So if I'm going to go back here to, so normally when I talk about this stuff, there's a lot of conversation around different parts of it. So if we're using the trauma-informed care principles of empowering people and listening to them, then we can kind of help them to regulate in this setting. So just being able to implement kind of these different steps with our interactions, and being being therapeutic. You don't have to be a therapist to be therapeutic, can help them to regulate and to be able to engage more effectively, if that makes sense.
Absolutely.
So I did want to know what people think about some different steps that you can take to be able to implement a therapeutic milieu. What are some things that you can do differently to be able to help the milieu be more therapeutic for not just patients, but also for staff and everybody that might be involved in the organization?
So Tom says practice mindfulness. Sherelle says build relationships. Victoria says mutual expectations, making expectations of staff and patients clear to all. Amber says be an example, providing choices where you can, offer options, using check-ins. And Erica actually asked the question that they're curious if there are any participants who have a daily ritual. Sorry, my chat's moving, to start the day for staff. So that's one question. If anybody else out there has a daily ritual that they start the day with staff. Others are saying setting ground rules, giving respect, being non-judgmental, practicing empathy. Hello, Veronica, miss you. Recreation activities, picnics, games, be supportive of each other and doing check-ins, sensory tools. Administration needs to be aware of burnout and assist the staff with ways to handle it or deal with it. Rapport building to better understand patient needs, and maintaining open and relaxed body language, jumping on opportunities to engage in neutral moments, and listening to the individual reinforce acceptance and understanding of their feelings and thoughts.
Great. I heard sensory tools there, and that was something that I was going to add in here. But that is definitely an option for helping to regulate the milieu too. Um, Lots of really great responses here. One thing too to point out is that in order to, using it from a trauma-informed care perspective, and in order to be therapeutic, sometimes there's a misconception that we have to be excessively flexible and agreeable. And so there were a couple responses of boundaries and consistency, which doesn't may not always come across as being therapeutic, that it can be kind of misunderstood. But consistency when it comes to working with people with significant trauma histories, and the boundaries are going to be especially important for people. So people with these trauma histories are very sensitive to any external cues, and so being authentic and creating those boundaries and being consistent in our approaches is going to be especially important.
And one thing that we've seen, Debbie, in New Jersey as we work with the hospital staff is sometimes folks have difficulty understanding that validation isn't necessary, like validating one's feelings or thoughts, a patient's feelings or thoughts that you're working with is not necessarily saying that the behavior that they may be engaged in, which may be aggression or self-harm, is okay, right? So I don't know if you could speak to that at all, around validation and, how to differentiate that from permissiveness or, and how to do it well.
Right. Yeah, that's a really good point. So, their validation often gets, people think that if you're validating somebody, that you're also agreeing with their behavior or their emotions or what they're saying. And the truth is that all emotions are valid. Every emotion is valid, right? And so we can always validate how somebody's feeling, and then we can help them to understand if they're feeling, if what they're feeling maybe doesn't match the situation. Maybe we can help them to get to that point, but we can always validate somebody's emotion. And that's where, when somebody flips their lid and they're kind of running off of their emotion center, then we can, if we validate it, this goes back to name it to tame it again. If we validate that emotion and call it out for them and help them recognize it, then we can help to get that thinking brain back online. And then we can have a conversation about the situation and the details about that. So I saw that somebody said we validate feelings, not behavior. And so we only validate the valid also. So yeah, validation does not mean that we agree with something or that we're approving of the way that somebody is behaving or um, what they're saying, but it is just recognizing that what they're feeling is really truly what they're feeling.
Thank you.
Yeah. Okay, let me go back to,
And Tom mentioned that Linehan describes not validating the invalidatable.
yes,
Word.
exactly. Yeah, we don't want to validate something that is not valid, which would be behaviors, right? Like sometimes a behavior might not be valid, but that's also part of helping to get to be therapeutic, and to get the environment to be therapeutic is being able to get people to recognize um, when their behaviors don't match the situation. And but we can't do that if they're in this fight or flight mode. If they've flipped their lid, we have to get them back into the social engagement system to be able to get them into to be able to have that conversation with them, to talk about you know there's a reason why people behave a certain way, and maybe it was effective at some point in your life and it's not anymore. And so but people don't always recognize that because it's an automatic response. It's this fight or flight response that might not be appropriate to the situation anymore. But if we can't if people are dysregulated, then we can't really have that conversation with them, and we have to get them back to a place where we can talk to them about it.
So we have one question about what about fixed delusions? And I guess that's related to being able to validate, how the person is feeling, perhaps when they're having those delusions. I also want to mention before you answer, we do have a really good prep webinar on our site about working with individuals who are experiencing psychosis. So Amber, if you wanted to check that out, they do address delusions. But what do you think about, what do you have to say about that, Debbie? What about fixed delusions, and how do we, validate individuals for what they're feeling when they're, maybe perpetually experiencing that detachment from reality and not wanting to reinforce the delusion?
I think that you can still go back to validating their belief that it's real, right? That reminds me of, there used to be a time where, when people with dementia, that we used to correct them all the time, right? We used to tell them that no, we used to correct their beliefs when they were kind of regressing into a previous time of their life, and we would do this all the time, and it was just more traumatizing than anything else. But it's not always necessary to correct that fixed delusion. I mean, it's gonna, I think I would refer you back to that training that you're talking about. But generally, and if we're talking about kind of a milieu in interaction, that it might not be the best time to kind of challenge the delusion, but we can always validate somebody's feelings about what their belief is without confirming or denying that is a delusion.
Thank you. And we did have a comment come in from James that said the fear they may be feeling is real, if not the delusion itself. I think that's
Exactly right. That fear is real. So if we're talking about like a milieu interaction, then the fear is what we really need to address, because that's where things become less therapeutic, right? Because if somebody's living in fear, then they're going to do whatever they can to survive and to protect themselves. And a lot of times that is going to be um, presented as aggression or violence. And so if we can recognize that somebody is fearful, then we can help them with that fear rather than focusing on whatever the delusion is. And that's ultimately our goal in the milieu.
yeah.
I'll just remind people that that training was on LEAP. It's Xavier Amador's approach, and LEAP stands for listen, empathize, agree, and partner. So if his brother had schizophrenia, and he developed this approach to not challenge exactly what you're saying, don't challenge, but try to partner with the person to move ahead, you know, and definitely be empathetic to the situation.
Right, Tom. And I think it's important to mention that, you know, a feature of a lot of psychotic disorders like schizophrenia and other related disorders is this idea of that word anosognosia, where, you know, a person really truly cannot realize that they may have a disorder, that the thinking is so real. And I would encourage anybody to look up Xavier Amador's TED Talks and things like this, because he does some really good scenarios or role plays to really drive this home to individuals. Thank you. Just wanted to add that.
I had forgot to ask at the beginning, but what can people give me an idea of what disciplines everybody is and where you're from?
Tom is our fearless leader in the Department of Psychiatric Rehabilitation and Counseling at Rutgers. He's our team leader. We have social work from, I'm thinking, Austin State Hospital. I'm going to assume that is Texas. Behavior specialist, more folks from Texas. We have more social workers, psychology, nurse managers, several nursing, lots of social work, occupational therapy, recreation therapy, chaplaincy, co-occurring services, more nursing, program director, safety officer, OT again, education manager, clinical nurse specialist, treatment team leader, social worker, psych technician, nursing
Right,
executive.
we have. y-
That is what we have that has come in.
Oh, okay. Okay. Okay, so that's a good variation. So we talked for a minute. People gave some feedback about what kind of behaviors you see are, and then some of the different strategies that people take. I'm wondering if we can get a couple examples of difficult situations where some of the tools that you used haven't been effective in being able to regulate somebody? Does anybody have an example?
And if you have an example, you can either put it in the chat, or I can probably allow you to speak, as Tom was. Trisha has said head banging behaviors, Tom, traumatic brain injury.
So the head banging behaviors, that's definitely, that's always a challenge. Is it possible to let that person talk a little bit more about that if they're willing?
Trisha, would you like the microphone, or would you like to type in the chat to elaborate? Probably typing.
Okay.
Trisha, I'm going to give you the microphone. One moment.
I got it.
There you go.
Okay, can you hear me now?
Yeah.
Okay, I'm sorry, I was talking. I thought you could hear me. I was just saying that it's a behavior that's always concerning because, as Tom mentioned, it can lead to other types of traumatic brain injuries, and it's something that you see repeated in some of our individuals who obviously have a trauma history. And I was just wondering if you had any some tools or any suggestions from a trauma-informed perspective that you could share to help when we have an individual who is struggling, other than winding up in some type of restraint or a physical hold or seclusion. So I'd like to see another option other than that, and just thought maybe you could share your experience with this.
Yeah. So one of the things that I would like to do is invite other people to give feedback on things that have worked well for them in those situations. And I will say too that unfortunately, sometimes the despite all of our attempts to change the behavior, that sometimes it does end up leading to some form of restraints or seclusion or something to help them to regulate in a different way. But I would love to invite people to share what has worked for them in the past before I give my answer.
I can say it's interesting. I'm in the same system as Trisha. I don't know if she's heard about this initiative at one of the hospitals, but I believe it's called Eucora, and it's pads that staff employ. So instead of the person hitting the wall or whatever, something hard, they actually hit the pad. And the early results were extraordinarily positive. It prevented a lot of restraints. I don't know how we transition from the pad to not using the pad, but so that would be something to explore. I'll see if I can find the reference and put it in the chat.
Yes, please. Thank you.
Oh, there it is. Chris Dorian put Eucora. Anyway.
Yeah, I knew they were using those pads at Ancora also. Yeah, there were no other comments about that, Debbie. I didn't know if you
Okay.
wanted to
Yeah.
comment.
So I think that part of it is going to be also part of it is going to be finding out why this person is doing these behaviors, right? They have oftentimes different reasons why they're engaging in head banging behaviors. And so to be able to change that behavior, we first have to find out why they're doing it and what their what they're getting from that, so that hopefully we can replace that behavior with something that isn't harmful. So we have a DBT program. DBT has a lot of skills to be able to teach people to use distress tolerance. There's different distress tolerance skills, emotion regulation skills, to be able to use so that you can replace that behavior, stop those life-threatening or behaviors. We do things like ice diving, where we have a bowl of ice water where you basically you have to place your face into the ice water. You have to bend over and put your face into the ice water and cover this part of your face so that you can to activate the mammalian dive reflex, and which is regulating for people and helps them to not engage in those self-harming behaviors. But there's a lot of different DBT skills that can be used to help these. Yeah, so it's going to be a lot of helping people to regulate and finding something to be able to replace that behavior. I think that depending on the setting and the tools that are available to you.
Thank you.
We do have a question that came in from Tom asking if you believe that instrumental violence is related to trauma. Is it a trauma response?
So everything that I do is trauma related, and so I think that it absolutely can be. I think that that a lot of violence can be a trauma response. Especially when you come into a setting, these inpatient settings where we've got this really high rate of people with trauma histories, and that the brain development that occurs when you're experiencing complex trauma and multiple traumas while your brain is developing, and not being able to learn effective coping skills and being able to accurately identify threats in the environment, then our responses a lot of times can, that if somebody gets into this fight or flight mode where they're looking to survive, then any form of violence could come from that fight or flight mode, where people aren't really able to think through the situation and accurately identify it as maybe not being a dangerous or life-threatening situation. So I think it's certainly possible and very likely that it is trauma related.
Thank you. And Tom also mentioned the role of functional assessment. And is that or functional behavioral assessment, is that something that can be useful in, kind of determining where some of these problematic behaviors come from?
I think any form of assessment is going to be useful in determining the behaviors, for sure. Yeah, yeah, it'll definitely be useful. I'm not sure if there's more to that question.
Oh, it's I just in the literature, one of the underutilized approaches is applied behavioral analysis. It's kind of it's your point about understanding the function of the behavior, and then you can strategize to how to replace that that kind of negative behavior, or the behavior that's problematic, with something they can still get their needs met, but in a way that's less problematic.
Right, yeah. yeah, we kind of have to determine why somebody's doing it or what they're getting from it so that we can to get a better understanding. And when it comes to cases like, I think that there were a couple comments about traumatic brain injury. When it comes to some of those situations, we might not be able to get a verbal cognitive response that's going to be entirely useful in every situation. And so, and then just, you know, when it comes to any kind of trauma, that it doesn't have to be, um, people don't have to actually be able to explain their trauma. They don't have to be able to verbalize it. And oftentimes they're not able to. And so a lot of it is very much somatic based, like some of the, there were earlier when we were talking about some of the things that we see in the environment that a lot of them are, there's a lot of somatic complaints. And oftentimes whenever there's a lot of somatic complaints, it means that there is a trauma history there, and we can treat those somatic complaints even though somebody might not be able to verbalize whatever that trauma is, because is it Bessel van der Kolk, the body keeps the score. We carry that trauma with us in our body whether or not we're able to talk through it or not. So sometimes we might just have to treat something somatically rather than cognitively.
And Tiffany mentioned that this is just another reason the body-based stuff is so important as a first phase in learning to regulate and establishing a sense of safety, right? So kind of laying that groundwork for engagement and connection and validation of the person's experience so we can kind of move forward to, you know, gain better understanding of what the function of the behavior is, what the person is seeking, you know, out of that behavior.
Exactly. And it's all stage 1 trauma treatment. And that's also where some of those sensory tools can come in, and being able to help people use different tools to be able to regulate and learn how to have a more regulated nervous system and be in this social engagement system of in the nervous system, so that the more often that they're in this area, the more regulated that they're going to be in general. And that's when they're going to be able to retain the information of these tools that they're able to use, so that when they do start to escalate, maybe into the, you know, as on the left side of this, the polyvagal chart, where the arousal starts to increase, once that starts to happen, they'll be better able to recall those tools that they have, and bring that thinking brain back online so that they can accurately so that they can perceive the environment accurately when there isn't actually a threat involved in getting to that sense of safety.
Thank you. And we have a statement from Julia who says that she finds at her hospital she has a hard time figuring out how to reduce violence, that especially related to patients verbally insulting each other, and the other patient reacting with violence impulsively.
Yeah, that's a process too, right? So that, and especially if when we were talking more about in a forensic setting, and some behaviors that are maybe considered more, oh, what's the word I'm looking for? There's kind of like a prison mentality that somebody might have if they're in and out of the system for a long time, where being insulted is an extreme threat, and they have to deal with that in that way. And so getting people to a place where they can kind of tolerate that and do something differently, that's going to be the first step. And it takes a lot of skill to be able to tolerate that and regulate repeatedly in order to not react impulsively. But it's that the window of tolerance, right? Like how much somebody's going to be able to tolerate uh, is that's going to be the key. As soon as we can get them to kind of tolerate a little bit more of that, then they can change something. They can change that reaction.
Okay, I see no other questions or comments at this point in the chat. I just want to let everybody know we have about 5 minutes remaining in the webinar. So if you do have any other questions or comments, and I just saw another one pop in, please feel free to type it in the chat or let us know if you would like to speak. We can give you the mic. Tiffany mentioned that another thing that can support a therapeutic milieu is good use of therapeutic community meetings. And that is something here in New Jersey that they have, that they are trying to implement, and many places have, especially utilizing the safe wards model. And Megan says, tell me more about therapeutic community meetings. So I don't know if you could speak to that, Debbie, with the time that we have left.
Yeah, so our hospital system uses therapeutic community meetings where all of the patients get gathered together. Ideally, all of the patients gather together with as many staff as possible to talk about their home, right? That they're all living together in this community and trying to kind of get everybody to be on the same page, to understand what how the unit works, to get everybody to get to know each other, to be able to express what their any concerns that they have, or to be able to kind of help each other out too. I don't know, I'm trying to like rush through kind of a response to that, but I don't know if Tiffany wanted to add anything else.
No, that's great. And I would refer folks to, I believe it's safewards.net. I believe that it is. And they have some great resources also for community meetings aimed at reducing inpatient violence. Um, Sherelle, how can you get copies or recording of the trainings? There you go. Jen is answering that question. And Tom has, this might be our last question, but have systems been successful in implementing trauma-informed care principles? And I guess to take that a step further, do we have outcomes, or how do we know that systems are effective at implementing trauma-informed care?
Um, I'm wondering if Tiffany would be willing to answer that, but I do think there has been success in it, and we are very much in our process of implementing it, and we have seen some successes. But yeah, I don't know. I feel like that's a really long answer too. There's probably you'll probably be able to find some research on that online. I don't think that I can answer that in the 2 minutes that we have left, but I do think that there has been some success in doing it. I just saw Tiffany's comment come through too, that she would be happy to share some information about it.
Yeah, absolutely. Tiffany, if you're comfortable putting that in the chat so that others may be able to reach out to you, you may get an explosion in your email inbox. But if you are comfortable with doing that, please feel free. I think that we had, okay, so Stacy said that at their hospital, they started a journey on trauma-informed care years ago. We've seen a drop in restraint. And seclusion, a marked drop, which has also resulted in lower injury rates for staff and clients. And thank you, Tiffany, for dropping that in the chat. We appreciate it. So we have 1 minute left. Any other questions for Debbie while we have her with us?
Dawn did put the link to the training evaluation in the chat box. If you can't do the training evaluation today, you'll get a follow-up email in the morning that has all that information. And don't forget, on the training evaluation, you can access the slides, the handouts, and you'll have a link to the website to access the recording when it's available.
Thank you, Tom. Thank you for participating. We want to thank everybody for your dynamic interaction, your participation. And Tiffany does say that Debbie, her, and the team would love to connect with everyone who's interested in learning more. So thank you both for that, for putting yourselves out there for that. And thank you to everybody today.
Okay, our next prep will be November 19th. Stay tuned for registration information, and we'll see you all next month. Thanks, everybody.
Bye, all.